It's my great pleasure as Chief Medical Officer of the Australian Commission for Safety and Quality in Healthcare to welcome you to the first webinar of our Better Care Everywhere program series. My name's Robert Hercus, and I thank you all for joining us today. In the spirit of reconciliation, the Australian Commission on Safety and Quality in Healthcare acknowledges the traditional custodians of country throughout Australia and their connections to land, sea and community. We pay our respects to elders past and present and extend our respect to all Aboriginal and Torres Strait Islander peoples. Thank you for joining us today. At the moment, there are 400 people on this video conference, the first attempt for the Commission to run a conference. Today's webinar tackles one of the really important issues in healthcare delivery, and that is variation. When is variation appropriate and a good thing? And when is variation inappropriate and not in the best interests of our patients? The Commission's role in Australia is to lead and coordinate improvements in safety and quality in healthcare. And we see appropriateness of care as a big part of this. Mapping healthcare variation with the Australian Atlas of Healthcare Variation has helped us identify clinical areas where there is variation that needs explanation and where further work may be required. Even more importantly, mapping variation has prompted us to examine the appropriateness of care in hospitals and primary care throughout the country. As you can see, this webinar is interactive. I encourage you to post questions and use the chat function. The chat function allows you to talk to the public chat function allows you to talk to other participants. The question manager allows you to ask questions of the panel. And after the sessions from Professor Duggan, we will be running a live chat, a live interactive discussion with Professor Piccone and Professor Duggan. There on the top right-hand corner of your screen, there are some important icons that you will need to know how to use. There's a purple speech bubble icon, which will allow you to chat to other participants. Please don't post your questions for the panelists to that icon because we won't be monitoring that for questions for Professor Piccone and Professor Duggan. The dark blue hand icon allows you to submit questions for later on in our question and answer session. The orange icon is for notifications or audience messages, and the green arrow icon allows you to refresh the page if you experience any difficulties. The red cross icon will allow you to exit the webinar. This webinar is being brought to you by Redback, and there's a Redback team available to support you if you have problems with access to the webinar. And they're available on 1800 733 416. And feel free to contact them if there are any problems. The first of our two talks today is by Professor Duggan. Conjoint Professor Anne Duggan is a clinical director of healthcare variation here at the Commission. She's a highly respected gastroenterologist with significant operating and leadership experience in a range of healthcare settings. She's passionate about improving healthcare services through sharing knowledge and collaborating across all aspects of healthcare. Anne Duggan has led the development of the Australian Atlas of Healthcare Variation from a clinical point of view and has done a lot of work exploring variation within our system. So the first of our two talks today is, so what is healthcare variation? Given so many competing demands in healthcare delivery and healthcare needs within Australia, why is variation important? Here Anne makes the case for examining variation and understanding healthcare variation within hospital and primary care settings. So the first video.
I'm Anne Duggan. I'm Clinical Director of Healthcare Variation, the Australian Commission on Safety and Quality in Healthcare. I want to introduce you to healthcare variation, a topic which I think is incredibly important if we want to have a healthcare system that works best for everyone. I want to start by telling you a story of, let's call him AM. He was a young man who presented to my outpatient clinic a number of years ago. He was critically ill, the effects of chronic diarrhoea and inflammation. Desperately ill. He was a security guard and he'd taken to carrying an extra pair of pants to work in case he had an accident. He said he didn't know how to access an earlier appointment with his GP or with the outpatient clinic, so he just soldiered on. By the time I saw him, it was too late to do anything medically. He needed an operation to remove his bowel. Unfortunately, he survived that. AM's story is a powerful example of healthcare variation, when care varies from what we know is best practice. That's, in his case, early intervention when disease becomes active, and ideally maintenance of remission so that the disease does not flare up. Now, the critical question is, if you looked at patients like AM across Australia, would he be an isolated standout? Or would you find other patients whose care varied from best practice, and that care was not because of their preference or need? Because that would be unwarranted variation. That's what we really want to focus on. Now, in the case of AM, you notice that it was not because he didn't know he needed medical, not because there was no healthcare system near where he lived or doctors to provide the care he needed. His events occurred because he didn't know how to access the healthcare system. But more importantly, the healthcare system didn't make it easy for him to access it. It wasn't of his choosing. We were fairly devastated by what happened to AM. We were determined to rethink our system to ensure it didn't happen to any other patients. It was too late to help AM, but we had an obligation to fix our system so it didn't happen to others. We rejigged our service and used funding that we had for another purpose to fund a liaison nurse whose job it was to help patients with similar problems. Patients could directly access this nurse by phone. That way we could ensure they would get appropriate triage. They would be seeing us when they needed it, not when it was their turn, according to the predefined booking. They could get rapid advice, they could get support, they could get urgent review. As you can see from the case of AM, examining healthcare variation is critical to providing quality care. We have to address the causes of unwarranted variation because it has huge benefits for patients. And of course for us as clinicians, because we all want to provide the best possible care to every patient and every time. For today's talk, I want to dig deeper into why healthcare variation matters. I want to explain the difference between warranted and unwarranted healthcare variation. I want to emphasise how data about healthcare variation is pivotal to starting that journey to improve healthcare outcomes. Most importantly, of course, tell you what you could do in your sphere of influence to contribute to making the healthcare system better. Drive out unwanted variation. So let's think about healthcare variation. We've made massive gains in both life expectancy and the quality of life for thousands of people through new ways to diagnose conditions, new ways to treat conditions, the development of new medications and new surgical techniques. Despite these marked improvements, we're still seeing marked variation in the provision of best care. You see it across countries, within countries, between cultural groups, and according to insurance status. There's inequity of access and a failure to deliver services fairly. We see indication creep, the use of technology and medicines beyond the evidence base, bringing risks of harm and sometimes unknown benefits. We see gaps in the use of evidence. We at times know the evidence, but it's not being practiced, demonstrating the need for clinical care standards and those standards to be known by everyone, the system, clinicians, consumers. And we know at times we have inadequate system supports. We need changes in the way we design our healthcare systems, better provide the care that's needed, to provide better training and appropriate training of the right workforce, and the right financial incentives and disincentives to promote best care, to stop inappropriate care. Now, some variation is warranted. Healthcare variation can be the hallmark of a very sophisticated healthcare system that is reflecting the differences in patient preferences or needs. So you will see variation because of differences in healthcare needs due to age, gender, risk factors, and of course preference. Take, for example, osteoarthritis. It's much more common as we get older, so you'd expect much more healthcare related to osteoarthritis in older populations. Breast cancer, much more common in women than men, so you'd see a gender difference in the use of investigations and chemotherapy for breast cancer among women. Likewise, when you see groups of people with risk factors for disease, then you see more treatment of that disease in that group. And probably the perfect example is smoking and lung cancer. Smoking is a powerful driver of lung cancer, and so you would expect to see more treatment in smokers. But of course, there's preference that may drive variation. If you're overweight and have osteoarthritis of the knees, then you may choose to do exercise and lose weight because there's evidence that that makes a substantial difference to the pain in your knees, and for many people obviates the need for surgery. Other people may choose to go to surgery. So that's warranted variation. That's a great, sophisticated healthcare system. But there's unwarranted variation. An unwarranted variation is where the variation can't be explained by either patient need or preference, and it's typically an indication that something needs to change, be it in the system, be it among clinicians and the way they work, or consumers and how they use the healthcare system. The system might not be efficient as it should be, or it may not be effective in providing equity of resource allocation, or the way it uses technology may have problems. It may not be using the latest or providing the latest technology, or it may be allowing that technology to be used beyond the evidence base or its benefits. Clinicians. There may not be an appropriate distribution of clinicians, and we see that in Australia, the difference between metropolitan, rural and remote areas. The skill mix may be wrong. If you're a diabetic, you need not only to have access to a diabetologist, but many other people to look after your feet, your eyes, etc. The skill mix is also important. But of course, having people there is not enough. We need to have clinicians using the best evidence. So variation can quite clearly occur when people aren't applying the evidence. Consumers can clearly have too little or too much access. Access can vary due to geographical differences, which I just mentioned. Your access in remote Australia is far different to your access in metropolitan areas. Financial barriers are increasingly a cause for unwanted variation. Consumers can also not be aware of the risks and benefits of treatments and have poor choices. And for that reason, we really do promote the idea of consumers partnering in their care, being informed of the risks and benefits, the options, and making informed decisions so that patients are getting the best care for them. Well, why does it matter? I think you already have an idea as to why it matters, but I think one of the best and the first studies to really look at healthcare variation was a paper published by Glover 80 years ago. Glover study is fantastic for looking at variation at a large scale. Looking at the data at a large scale allows you to see things that you don't from your isolated perspective. And 80 years ago, Glover looked at tonsillectomy rates among school children in school districts across England and Wales. He himself was surprised at the results. He made three, I think, very pertinent observations. One, if you don't look, you won't notice what's really going on. Two, if you don't look, you won't see the harm that is going on. Now, the third thing that Glover said was, why does variation occur? He couldn't explain it, and he said it defies explanation, save for the difference in medical opinion about the indications for surgery. We've moved on from that. We know much more. Before we move on, let me quote one other thing that Glover said, that the mortality directly due to tonsillectomy was greater than is usually appreciated. His study told him something that he wouldn't have known from his own practice. In the modern era, we've moved on to atlases, and the first group to do that was the Dartmouth group in the USA. And you can see just from that map how powerful atlases are at describing the healthcare variation that Glover was talking about. Here you can see quite almost a mosaic of differences that don't make immediate sense and call for inquiry as to what is going on. Well, in 2015, Australia started doing atlases of healthcare variation. This provided us with the data to look at common conditions and their management and to see what was going on and how much variation occurring. It enabled us, it provided the platform for healthcare reform. Let me give you just one example. As I said, osteoarthritis of the knee is very common as we age. It affects a large proportion of people. So if we don't get the management right, it affects a lot of people. If people don't get the care they need, they're harmed. If they get care that they don't need, they get potentially exposed to harm without benefits. So it's incredibly important that we get it right. So we looked at arthroscopy and we also looked at knee replacement. And in each case we identified the variation, we investigated, we addressed it. So in the case of arthroscopy, which is that keyhole surgery into the knee with a camera on that telescope that allows you to look inside the knee, we looked at the data in the first atlas on how much was going on in Australia. Now, one of the key reasons for looking at that was as early as 2002, the evidence from randomised controlled trials was really questioning the benefit of arthroscopy in many clinical scenarios. And clinicians were beginning to get concerned about its use outside best practice. Now, what you can see, however, on the left-hand side, if you follow along the x-axis, the horizontal line, that's 1995 to 2017. And if you look at the vertical axis, which measures the number of MBS funded surgery, that's a medical benefit scheme funded surgery, there was a continual rise in arthroscopy beyond 2002 and only a recent fall. Surgery skyrocketed, really, for 10 years after the evidence came out showing that it didn't benefit the majority of people with osteoarthritis of the knee. So we looked at arthroscopy, we mapped it, we found that there were 33,000 admissions for knee arthroscopy in 2012-13. We found marked variation with particularly high rates in South Australia. So on the right-hand side, you can see Australia, and we've broken it up into regions called SA3, which are the national system for describing the distribution of the population. And then we've standardised the data so it's valid comparison. We mapped by where people live. And so if you look at that, you can see there's a marked variation. High rates in South Australia, but in other parts of the country, very low rates. It was a seven-fold variation. 7 times different between the lowest and the highest. So what do? We fed the data back to states and territories. We fed the data back to the local health services, and we provided the data to the Commonwealth, who are the funders of the MBS, and they revised the funding of knee arthroscopy. We identified in discussions with clinicians and consumers that there was a gap in the guidance to support best practice, and so we developed a clinical care standard to fill that gap. As a product of that feedback and that activity in developing and promulgating a standard for use to help clinicians, to help health services, and to help consumers to provide and receive best care, the rate of knee arthroscopy in Australia has halved since 2012. 2012, the rate was over 500 per 100,000. 2019, it was less than 250 per 100,000. Hope it will continue to fall until it reflects the appropriate use of knee arthroscopy. And what can you do? It's important to support everybody in the system to reduce unwarranted variation. And everyone has a role. Go to our website, because on our website you can find a multitude of resources. You can find our atlases, you can explore our atlases and look at the interventions that we've mapped. And we've got another atlas coming out this year, which will also be on our website. We've developed a user guide, and that is a step-by-step guide to help you in the process of identifying and addressing variation. And in that guide, we've also included examples from clinical groups who've done a great job in their area of expertise to reduce variation. They're very happy to share their examples. That's there for you to use. You can also access the clinical care standards so you know what best practice is, and you can use those resources to promote best practice. I think all of us clinicians have a responsibility to measure our outcomes against our peers, against relevant standards, and where they're available, against outcome data from registries. I urge you, go to the website, download the user guide, start looking and discovering what's going on in your area. But before you do that, join me in the second of our series on the Atlas, where we look in greater detail at what we've been doing in the Atlas. And that's beginning to be followed question and answer session. Thank you.
Thank you, Anne. That was really fascinating, the big picture of variation. For everyone on this seminar, I'd like to remind you that we have a chat function, so you can chat to the other participants on the seminar, and that's the big purple button on the top right of your screen. We also have a question generator so that you can ask questions of Professor Duggan and Professor Piccone in our chat session after the next presentation. And that's the blue hand, again, at the top right-hand corner of your screen. If you have any problems with the seminar, you can ring Redback Support on 1800 733 416, and I'd encourage you to do that. So now we've discussed the broad, big picture of variation. What I'd like Anne to talk to us now is about how the Australian Atlas of Healthcare Variation fits in with that and what variation looks like in Australia. So over to you, Anne.
Hello, I'm Anne Duggan. I'm Clinical Director of Healthcare Variation at the Australian Commission on Safety and Quality in Healthcare. This is the second in a two-part series introducing you to healthcare variation and to atlases. In the first of our series, we discussed variation, the difference between warranted and unwarranted variation, and why it's so important to identify unwarranted variation so that we can drive more appropriate care. In this, the second of our series, I'm going to look at the Australian Atlas and atlases of healthcare variation and discuss some of the findings we've had, some of the surprises we've had, but also some of the great work that we've been able to do and clinicians and health system managers and consumers have been able to drive as a product of the data that the atlases have revealed about some very important areas of healthcare provision. Let's start. One of the most surprising experiences I had the atlases. I don't know whether it was a surprise to you, but it was certainly a surprise to me to find that Australia has one of the highest rates of hysterectomy among countries belonging to what's called the Organisation for Economic Cooperation and Development, the OECD. It was a surprise to me because hysterectomy used to be the only treatment available for heavy menstrual bleeding, but those days have gone. We've developed the oral contraceptive pill, we've developed the intrauterine device. Clever surgeons have even developed minimally invasive surgery to remove the lining of the uterus, which is the source of bleeding, without needing to have the major surgery of removing the uterus. When we ask clinicians why it might be that Australia, despite its sophisticated health system, should still have a high rate of hysterectomy, the answer was that it was the tyranny of distance. Women in rural and remote areas would still opt for hysterectomy because it was definitive treatment. They couldn't afford to travel the hundreds of miles with overnight stays for treatments that might not work. They needed the once only definitive treatment. Seemed plausible? Then we explored the data. To my surprise and the surprise of the experts we consulted, when we looked at the data, mapped the data in the second atlas of healthcare variation, we found that most of the highest rates of hysterectomy were not in remote areas, but in inner regional areas of Victoria. But without an atlas, efforts to increase access to these effective low-risk treatments would have been wrongly targeted. The women in greatest need in these regional areas would not have been informed of more appropriate, less invasive treatment options. Because we wouldn't have considered them to be part of our target area. I find Atlas findings recurrently surprising and challenge my preconceptions and misconceptions about healthcare, how healthcare is being delivered in Australia. I find stark differences between regions, by socioeconomic group status that I don't expect, differences between Aboriginal and Torres Strait Islander groups, differences by gender when the diseases being treated aren't different between the genders, and differences by funding status. And again, it raises the question of how consistently we are providing appropriate care. So what do we stand to gain? Well, atlases allow us to get that big picture that we don't see from our isolated perspectives. It means we can address healthcare problems on a bigger scale, target areas of greatest need, and ensure that more people consistently receive appropriate care. Fewer people will be unnecessarily harmed because they will get the care they need, or they will no longer be receiving interventions that they don't need. And we'll end up with a much more efficient, effective system that benefits all of us. Atlases contribute very much to this review of the data because they clearly demonstrate what's going on. It's that visual image. A picture paints 1,000 words. The Dartmouth Group in the US were the first to use atlases. And since then, a number of countries have taken it on as a means to drive healthcare reform. Canada, European countries, Australia, New Zealand. In our Australian atlases, which we started in 2015, we've looked at medications, healthcare interventions and surgical procedures. We've selected the medications that really are critical to get right. In the first Atlas of Healthcare Variation, we looked at antibiotic use. We know that the overuse of antibiotics is leading to antibiotic resistance and increasing difficulties treating infections to the point of not being able to treat. And we know already that our rates are much higher than other countries. So it was important to get that data. We've looked at antipsychotics, again a problem area, opioids and many others. We've looked at healthcare interventions and surgical procedures, such as operations for back surgery, for knee surgery, cataracts, areas where we know that we want to get it right. Now, with our atlases of healthcare variation, we've mapped according to place. So we know what it's like for people living in different parts of Australia. It's not where you receive the care, it's where you live. We've mapped according to statistical area 3s, SA3s. So we divided up the country into those 300 odd SA3s, and that's populations of up to 300,000. So you can imagine the SA3s are quite small in the densely populated metropolitan areas, but quite large in those rural remote areas. We've gone beyond that to then further analyse the data and categorise regions according to whether they're metropolitan, regional or remote, to see whether there are differences and patterns and consistent differences between the groups. And then with each of those regions, we've allocated the areas within, for example, metropolitan areas into their socioeconomic status, providing a wealth of data. The data we've used is administrative data from the Medical Benefit Scheme, the Pharmaceutical Benefit Scheme, which supports our medications, from the perinatal data set and from patient admission data. We've looked at insurance status, where the data is available, Aboriginal and Torres Strait Islander heritage. The results have been surprising. We found a 12-fold variation, according to where people live, in hospitalisations for diabetic complications across Australia. It's extraordinary. You would expect some admissions to occur for diabetes, but you'd expect that a highly sophisticated health system would ensure that people were able to manage their diabetes in the community with access to a diabetic educator, a GP, a diabetologist, a podiatrist to look after their feet, someone to look after their eyes, and that admission would be a very uncommon thing. We found 30-fold variations in MBS-funded colonoscopy. That defies what we know about the epidemiology of disease and what we know about the evidence for the appropriate use. We found a 75-fold variation in the dispensing of medications for ADHD, suggesting that there are, when we talk to the experts, two groups of thought about the place of these medications in the management of ADHD. So using Atlas data enables us to explore differences, socioeconomic status, remoteness, in cultural groups, between cultural groups, in insurance status. It enables us to develop some hypotheses as to what may be going on, such as, is there an evidence practice gap? Is there indication creep? Is there a workforce issue? Undersupply in some areas, oversupply in others. And so it allows us to refine actions to really drive down the unwarranted component of that variation. So let's consider in more detail some of the drivers of unwarranted healthcare variation. As I said at the beginning, to our surprise, we found that the high rates of hysterectomy were in regional places like regional Victoria, 6 out of the top 10 from there. So it raises the question, are women in those areas getting all the information about all the treatment options? And are they getting the access to those treatment options so they can choose what's best for them? Now, we mapped endometrial ablation. That's that minimally invasive surgery I described that removes the lining of the uterus but saves a woman from having to have their uterus removed. We found a 21-fold variation. It really raises the question of whether women have access across the country to that procedure or whether they have to choose the more invasive surgery. Let's think about indication creep, because it's an important issue when we have the availability of many medications and many new technologies, and the possibility that they may be used beyond what the evidence shows about their benefits. In 2012-13, there were 38,500 admissions for tonsillectomy in Australia, and there was a 7-fold difference between the rates in the lowest and the highest areas. Now, we know from data from the UK and US and elsewhere that there has been a consistent decline in tonsillectomy for tonsillitis. But in a number of countries, there's also been a rise in tonsillectomy for obstructive sleep apnea in children. So the important question that we need to ask when we see these rates and we see the 7-fold difference is, what's the evidence base for this indication? How good are the data? Are the studies comparing surgery with watchful waiting? Are we looking at outcomes to know that we are doing good, not harm? What about workforce? Another driver. I said earlier, metropolitan areas have much higher rates of colonoscopies than regional and remote areas. Surprisingly, and contrary to the epidemiology of disease, the rates are highest in the highest socioeconomic groups in metropolitan. Yet we know that the risk factors for bowel cancer are more prevalent in lower socioeconomic groups. So can these rates in metropolitan areas be explained by supply-driven demand? Take, in contrast, diabetes, a 12-fold higher rate of hospitalisation, diabetic complication. They occurred in predominantly remote areas. So is there a lack of those service providers I talked about? Do we have the right mix of providers so that people can manage their diabetes, prevent complications, and not need to be admitted to hospital? So how have the atlases driven change? Well, we've made changes in a number of areas, but let me just talk about a few. The Commission, with clinicians and consumers and health service managers, have developed clinical care standards for a number of conditions where we've seen that there really seems to be a gap between evidence and practice. So we've developed clinical care standards for heavy menstrual bleeding, for management of knee pain, hip fracture, for cataracts, the use of colonoscopy. And what those standards do is just list the 8 or 10 key evidence-based or expert advice-based practices that should occur in the management of these conditions. Those standards are now available very easily on our webpage. I recommend that you review. We've also fed the data from the Atlas back to the Medical Benefits Scheme, and you'll know that we've had a recent MBS review, and that data has informed some of the changes, such as in the MBS item numbers for colonoscopy, for arthroscopy, and for back surgery, all to promote evidence-based practice. We've also informed the national standards. So in the second edition of the national standards, you'll now see the standards which are used to accredit all our hospitals and day surgeries, recognise the need for health services to provide the data on healthcare interventions back to clinicians so they can examine the data and look to see if we've got variation going on, and they can explore the data and identify and reduce unwarranted variation. And the Commission has provided a guide which is available on our website to help people do that. Atlas findings have also informed our national workforce strategy and are helping to promote better distribution of our workforce. But let me end by giving you a case example. And let's go back to hysterectomy. As I said earlier, we found we had, compared to other OECD countries, a really high rate of hysterectomy. When we looked at our Atlas data and broke down the data by where people live and mapped it, those SA3s, we found 7-fold difference across Australia, but we found over 6 or 7 of those highest rates were in regional Victoria. And as you can see from the map, when you colour code by volume the SA3s and give the areas with the highest rates, the dark blue, and the areas with the lowest rates back to a yellow, you can see the marked visual difference of lower rates around Melbourne but higher rates in regional areas. And those higher rates were quite impressive. So for Ballarat, for example, the rate was 744 per 100,000, whereas the rate for women having hysterectomies in Melbourne was 119 per 100,000. So what actions occurred as a product of that? Well, the Department of Health and Human Services in Victoria and Safest Care Victoria took the data, drilled down on the data. They got their clinical work group to look at the high rates of hysterectomy, and there was a conclusion drawn that there was unwarranted variation. They collaborated to promote the Commission's heavy menstrual bleeding standard and engaged their local primary health networks to develop pathways that follow the standard and manage heavy menstrual bleeding according to the standard. And they developed clinics such as Well Women's Clinic, which were designed to offer choices in primary care as a circuit breaker for women who might otherwise be on a trajectory straight to surgery. The outcome is already showing promise. In 2014-15, when we mapped hysterectomy, the rate was 281 per 100,000. The rate of hysterectomy in 2018-19 was 236, a 16% fall already. So what next? I'd recommend that you explore your data, strengthen your hypotheses about what's going on, and refine your actions to reduce unwarranted variation. You can contribute to improving healthcare by looking at variation in your practice and benchmarking yourself against best practice, against your colleagues, against registry data, and implement changes to promote appropriate care and disincentivise inappropriate care. Resources are available on our website. I said the user guide and examples from clinical experts who've done it, who are very happy to share their knowledge and expertise. But in the meantime, can I suggest you stay and join us in a question and answer session? Thank you.
Thank you, Anne. That was really fascinating. And I'm sure everyone that's heard this will now be a lot more knowledgeable about variation and the impact of the atlas. For everyone on the seminar, I'd like to thank you for the questions that you've sent in, and ask you if you'd like to send any more questions. At the top right-hand corner of your screen, there's a blue icon, which is a hand. And if you push that, you can send us questions that I can now present to our panel. So our panel discussion today is Professor Anne Duggan, who I've already introduced, and Adjunct Professor Deb Piccone, AO, who's the CEO here at the Commission, and a very, very important member of the healthcare community, having been Executive Director of New South Wales Health, and served in Southeastern and Illawarra Health Service and Southwestern Sydney Area Health Service. Deb's made significant contributions to healthcare across Australia over many years, and has some really interesting answers to some of the questions that you've sent in. So I'm going to now ask Deb and Anne to respond to some of your questions. So the first question, Professor Piccone and Professor Duggan, comes from a member of the audience who asked, how do you choose the topics to be examined in the atlas?
Excellent question, and Dr. Hercus, thanks very much for your welcome, and it's great to be here this afternoon with everyone. The way we initially chose the topics, funnily enough, for the atlas was our first atlas was as a part of an atlas with the OECD. So the topics were actually chosen by that group. But that was the first time we realised that Australia really was leading the world in a whole range of areas. One, having the highest hysterectomy rate in the OECD with no good reason. One of the highest cataract rates in the OECD with no good reason. You've heard about the arthroscopies, certainly one of the highest users of antibiotics, attention deficit disorder medication, and certainly the inappropriate use of antipsychotics. So that was our first foray. And then it occurred to us that we'd learnt so much from that we'd go on and produce a series of atlases looking at a range of topics. So we obviously then placed those topics back in for a much closer examination, but we generally are looking for something where the jury's out a bit on the evidence that this procedure may be beneficial. Some thought that there may be overuse of it, which was certainly the case, say, with arthroscopies, or the inappropriate use of medication, which was certainly the case with antibiotics. So there's usually months of research goes on prior to choosing a topic area. But it certainly has to meet some of those criteria, that there's a concern that there may be inappropriate use. Early on, we of course put in some of the favourites to go back to the Glover paper, which I was so pleased to see from Prof Duggan around tonsillectomies. So it's pretty scary to think that it's 80 plus years and we're still talking about tonsillectomies and the appropriateness of those, and whether just simply waiting rather than taking the tonsils out is a good idea. And Australia tends to go through waves, and in fact, Prof Duggan and I were just talking about that, where we'll see a big uptake for no reason at all. So we've been through a period where tonsillectomies have increased just over the last 2 years, and it's almost inexplicable. We don't know why, and we don't understand it. So that's why we then go in to study it. We work with experts to help us select the topic. So we ask leading clinicians generally to work with us to make certain that we're not wandering down a pathway that's unnecessary. And we've been very fortunate to have very senior people guide us through all these examinations. So that's it in a nutshell. It's a little bit more structured than that. There's a score sheet that goes with it, but that's basically how we select the topics. We'll also go back and re-examine an area. So if we think there's been no progress at all, and in fact, if we feel we may have gone backwards, we'll go back and re-examine it. So at the moment, we're looking at one area is concerning us considerably, and that's the care of people with chronic disease. And that's been on our books now for 6 or 7 years. And in fact, that situation hasn't got better. It's in fact worsened in our view. And that will come out when we publish the next atlas.
When we looked in the first atlas, we looked at lower limb amputations and for
As a proxy,
diabetics,
yeah.
and saw higher rates in remote and rural areas, which suggests that there's underuse of all the things we know that a patient with diabetes should have access to in the community. I think that's why the potentially preventable hospitalisations data is so important to follow through, because there's good evidence of what you can do in the community and how you can help people with chronic conditions to manage their conditions so they don't get to a point where they need hospitalisation or rarely do.
We're never concerned about pushback. Sometimes we will get a bit when we're looking at some topic areas. So, for example, recently we've had a very close look at cataract surgery, mainly because there were some major changes in the UK in how patients were selected for cataract surgery, and from the clinical registry over there was quite a significant benefit. So we'll often then put one of those topic areas in if we think there's an opportunity for overall improvement.
Yeah, and the cataract story was an example where we went on and did a clinical care standard, because if you, for example, do have a waiting list for cataract, then I think the community is entitled to feel that at least the person in front of you needs it more than you do, and the person behind you needs it less. So you just don't have a first in, first serve. I think if we're going to use healthcare resources, one of the things about variation is you start to actually promote appropriate use of resources. And then, of course, you find out just how much you need, because the patient who didn't want their cataracts done anyway doesn't turn up to clinic to ask the question, why am I here?
So thank you very much for that. That's really interesting. There are a whole series of questions coming in online, so keep those questions coming in if you can. The next question is, when will the next atlas be released and what's in it?
Prof?
Well, it'll be in the next few months, the next atlas, and in that one we're looking at, there's some GI topics of gastroscopy and repeat gastroscopy, because we do know that people use those procedures more. We're looking at early birth, elective birth, because that's a really important issue, because we know that the development of the brain is very important, and children born early for no good reason have been shown to not do as well when you're assessing using things like NAPLAN scores. So we really think, and we've been advised by the obstetricians, that this is a really important area to get right, ensuring that kids get get the whole gestational journey so they've got the best chance in life. So that's one of the key topics we've got going there. We've got some ENT topics. We've
looked at spinal surgeries.
Yes.
So that's a repeat look at those. And of course, once again, that's another key area of appropriateness. There's a lot of evidence that these surgeries are simply not effective. It sort of goes back to the original argument of what to do with lower back pain generally. So it's going to be a very interesting atlas. There hasn't been an atlas that we've published where we haven't learnt some quite astonishing thing.
And of course, we're looking again at potentially preventable hospitalisations, because I think as chronic disease is such a major part of the health of many Australians, we really have got to do something about reducing unwarranted variation there. We really do have to ensure that everybody's aware of management for COPD, for heart failure, that's shown to be effective, and it really should be in place and accessible to everybody who needs it.
But based on international studies and even some local studies more recently, we could reduce the admission of people with COPD and heart failure and cellulitis and probably UTIs by up to 50%. But we keep providing quite disconnected care, particularly in rural and regional areas for people with these conditions.
And this is not just to create beds in hospitals.
No.
Hospitals are not without risk. A hospital stay, we all know, can be associated with iatrogenic injury. So this is providing what really is the best way to manage the conditions.
The most appropriate care.
Yeah.
Thank you for that. There's a really interesting follow-on question there. You mentioned early delivery. There's a significant variation in caesarean section rates across the country, and clearly that's a growing concern. And it's a complex issue with generational changing views around Caesar versus natural delivery. Can you give us some thoughts about how you might have a nuanced strategy to address those issues of caesarean section?
Well, I wish I could, Dr. Hercus, but I go back 10 years ago when I was the Chief Executive Officer of South Eastern Sydney Illawarra, and it had that learned institution, the Royal Hospital for Women, in it. And at the time, Australia was yet again leading the world, and we had the highest hysterectomy rates in the world. And I remember there was a 2-day clinical meeting to try and, do something to resolve this issue. And my view was that if we actually provided the mother and the father, the parents, with the correct information about the problems that can be associated with C-section, then we could probably reduce that. Now, that was 10 years ago, and all that's happened is the C-section rate has gone up. Now, there's no question at all now people are opting for an elective C-section. And I think as long as there's been an informed consent and people understand the risk they're putting themselves to and potentially their child, then that's going to go ahead, and it does go ahead, but it then brings in the problem of delivering these babies too early. And as Anne has just mentioned, then the risks that creates for the newborn baby being delivered too early in terms of brain development. And the evidence around that is very significant. So we've run a very significant campaign on that last year, and we'll be doing it again this year. But my view is the time for the campaign is over, and we really now should be looking at making changes to the MBS payment arrangements, and also the ability to admit people, having early planned C-sections without any medical or obstetric indication. It's a very significant problem, and I think we've probably talked about it for long enough, and I think that we now need to put some other lever in to make that move a bit.
I think the other component is that we really have got to have very balanced discussions about this. Sometimes I think people are only given the good side of something without the potential harm. And I think we are part of an environment. Everything we do has a plus and a minus. As a gastroenterologist who's interested in the gut microbiome, I'm very, very concerned and want to see much more research done as to what price a baby pays for not going through the birth canal. Now, I just don't believe it hasn't a role. I mean, we have evolved over centuries. So I think that when we're going to talk about doing it this way versus the other way,
then we really need to provide the data, or as clinicians, invest in getting those answers. Likewise, if you're going to have an antibiotic before you have your Caesar, does the baby get that? And what does that do to your gut microbiome? I think we're going to find, if we really take this very seriously, it's much more complex, and it's just not as simple as we've made some of our discussions. I'm all for choice, but I really believe as clinicians we have an obligation to give informed opinions and informed advice that is very balanced.
Okay, thank you very much. There's still some really interesting questions coming in. One of the questions is that data collection is relatively easy, but analysing that data and coming to conclusions is much more difficult. Can you point this attendee at any resources around how you might go around analysing data of variation?
It is very complex, and so we're fortunate in that we use the top people that are sitting at the Australian Institute of Health and Welfare, and in addition to that, we have epidemiologists here, and of course we've got a group of very senior clinicians that work with us on the data analytics. It's not something. It requires a team of very competent and trained people to actually analyse the data.
So what about the user guide?
Sorry?
What about the user guide?
Yeah, I think that if you, everybody has a role to play in this, and I think people have different access to different sorts of data, but to some extent, I think you don't need an enormous amount of data in, say, your clinical practice. I think, for example, like the example I gave you about that guy who couldn't get to clinic. I mean, you just sometimes need a bit of data to say, geez, well, what makes our system robust? And when you look at it, and you'd say, well, okay, we know there's a clinical care standard for the management of X, and you think, well, how do people know that? How does it work here? How do we ensure that it works on Monday as well as Saturday? Then I think just a little bit of data tells you, gosh, we've got a problem here. We need to explore it, and we need to benchmark against best practice. But I don't know how much data you really need to start to get a feel for how you're travelling. The user guide is certainly out there for people, and I think people have used it. I'd have to say in the user guide, the gastroenterology example was discovering a patient coming to our clinic with advanced cancer and realising that our system wasn't designed in a robust way to ensure that people who needed care got there first. And that's how we developed our direct access colonoscopy service. So we just used what data we had. In fact, we used medical students to actually collect our data. Well, what happened to the last 50 patients or 20 patients with this problem? So I recognise that in different parts of the system, we're resource poor in terms of dedicating people to data. But I think if you're there to provide the best care, you can always, you should prioritise,
I agree.
You do things, but accept the limitations of how much data you need and can get.
Yeah, so I was more talking about when you're actually publishing a national data set. It is complex, but I completely agree with you about local data sets. And so the richest source of data, of course, clinical data, are actually clinical registries.
Yes.
And that's now being completely revolutionised in that the clinical data from clinical registries is now being collected as the patient care is occurring. So it's real-time data collection because the algorithms are built in to the EMR systems, which is pretty exciting. The difference, of course, with clinical registry data compared to this sort of data is that the clinical registry data tends to just concentrate in very closely on a procedure or a condition. But the clinical registry data is getting very exciting.
I think the other thing is that if you know that there are best practice guidelines or clinical care standards, and you walk around your institution or your area of work and you can't see any evidence that nobody knows about them, nobody can find them, etc., etc. You don't need data to know that's highly likely it's best practice not happening and you've got unwarranted variation happening all the time. So it's getting that balance, get your clinical care standards in place, get your best practice, make sure everyone knows best practice and doing it, and measure as well. So there's, I think, a number of ways to solve the problem of reducing unwarranted variation, improving your efficiency and effectiveness.
Okay, thank you. You mentioned clinical care standards. There's been quite a few questions on the question line around the clinical care standards, with people saying they've implemented the clinical care standards but now want to measure whether they're achieving what they've set out to do. Can you talk us through how individual hospitals and individual clinicians might understand whether their adaptation and implementation of the clinical care standard is achieving what's desired?
Well, there's the indicators with all the standards that are there to do actually that. So if I take, and I know being a gastroenterologist, I always go in that direction. But for the clinical care standards for colonoscopy, you're getting there if your cecal intubation, i.e. getting all the way around the bowel, is at the adequate level. You know that you're doing it really well if, in fact, there are no patients who have to have a repeat colonoscopy because the prep's poor. So we've tried to build in indicators. And I think if you're interested in the area, then there are other indicators you can add on to that. And so, and what we've tried to do with some of those standards is actually build it into the endoscopy system. So if you build it into your systems, then you can monitor it. And then move on, if you're doing well, move on to another area where you are worried that you are causing harm or by omission or commission.
I guess another great example of that would be the stroke data, where the clinical care standard around strokes has indicators that are then in the stroke clinical quality registry and can be analysed by hospitals and health services. On that line, there's also... Sorry, Anne.
Sorry, I was just going to say, if you're using the user guide, you can then think about areas and what you think the benchmark should be based on international literature or based on what's collected elsewhere.
Right.
Sorry.
On the chat line, there's very significant interest in how health services and clinicians can get an understanding of the data for their area. There are questions about why use SA3, which is geographical area 3, so it's quite a large geographical area, versus SA2, which is a smaller geographical area, and lots of questions around how people can use their own data to look at their own variation. Does the Commission have any resources or help that might answer some of these questions?
Well, you can go online, go to our web site and explore the data. It's cut a number of ways. You can look at an area and look at it by SA3, look at it by PHN, look at it at a state level. It's designed to be cut as many ways as we're trying to sort of put ourselves in the shoes of others to see how they'd want to use it. So there's certainly that's a very useful tool to have, and I'd certainly recommend people look at it that way. And I think that I think it's up to also the jurisdictions have capacity to provide data as well. I think the use of SA3 over SA2, we have to be able to publish the data and not be able to have identifiable information, because when you use the MBS data, for example, you shouldn't be able to be so small that you can pick up. There might be just one practitioner doing things. So that's why we've used SA3. But as I say, we've also cut the data by PHN.
We will regularly suppress data because it is going to identify an individual practitioner. So it happens nearly every Atlas publication, and so far, as you know, there's been an act passed to protect the publication of MBS data generally, So from time to time, so for example, we found the highest prescriber of antipsychotics in younger people under 16 in a certain jurisdiction in Australia, and he or she were the highest prescribers, and we had to suppress that because there was only one psychiatrist in that particular regional centre. So from time to time, those sort of privacy considerations will come to bear.
I'd have to also say that though hospitals can, as we become more and more automated, have access to their own data, I think it is very important to look at things as we do in the Atlas by where people live. Hospitals serve communities.
Yep.
So it's how well is the community around you doing, and is it doing fairly if you're responsible for it?
Yeah.
So it is taking the perspective because to a consumer-focused care, which is what we really are trying to provide.
There's no question at all, though, some places are provided no data at all. I'll be quite frank with you. So if I was a clinician practicing in a certain area, I'm not really provided any assistance to do data collections, belong to clinical registries, even know that the Atlas was published and that it's relevant to my practice. Now, from our point of view, that's a major governance issue. It shouldn't be happening. People need to be provided that feedback and that information, and that's of course why it's now the subject of a standard in the national safety standards.
Yes, I think that's been certainly made it much easier for clinicians because there is an obligation on the institution to provide.
See, one of the great strengths of the Atlas is to provide information to clinicians. That's what, and I've been there so many times when they've actually been shocked about the results. I remember when the information came out about hysterectomies. Now, people knew the hysterectomy rates were high. I mean, one of the reasons I was given for not changing those hysterectomy rates was how could the registrars then complete their training?
Well, that's pretty awful, isn't
it? The same with arthroscopies. People knew the arthroscopy rates were the highest in the world. A lot of it was probably inappropriate, but there was one jurisdiction that was nearly 4 times higher than anywhere else. There was a jurisdiction in New South Wales which had the highest cataract surgery. Now, these are the sort of things that the Atlas does identify, and that information does need to get back to those clinical teams, and we do need to understand what that is about and why that's happening. And that's one of the great strengths of the Atlas.
Okay, thank you very much. There's also quite a lot of questions about, at the moment, the Atlas looks at procedures that are really driven by a combination of the patient or consumer plus the clinician, rather than system-wide issues such as waiting times or presentations in emergency department or systems issues. Can you comment around whether the Atlas is ever going to try and address variation at a systems level as opposed to variation at an individual patient clinician level? And are those systems variations important?
No, for the first time ever, I think I'm going to disagree with you. It does just that. It provides an agnostic look at variation across the Australian healthcare system. Now, what becomes evident as you drill into that data, that often a lot of what we call in inverted commas may be inappropriate procedures, a lot of those do occur in the private sector. So that the vast majority of arthroscopy occurred in the private sector. The vast majority of cataract surgeries occurred in the private sector. So I don't support your view that it doesn't show exactly what's going on in the system. In fact, it does.
I think the other thing is we've always taken the view, and if you read the Atlas recommendations and the commentary, and if you look at the way we structure our clinical care standards, all parts of the system have a role to play in reducing unwarranted variation. I mean, this is core business. Core business is providing warranted variation-based healthcare. And what drives unwarranted variation, as I've said in my previous talk, there's a component that's the way the system's structured, incentives to drive things the wrong way. It's related to consumers, their knowledge of their options and understanding their capacity to have access. It's driven by clinicians. But I think we've always tried to say, and I think that the sort of the take-home message from this work on variation is looking at what why we have a healthcare system. It's what our healthcare system is. So it's not going to go away. We actually have to, every day of our working lives, try and reduce it. And it's not just for one group to reduce. Everybody needs to be working now forever to get us to a system where we have a sophisticated healthcare system which only has warranted variation.
So, Dr. Hercus, let's talk about third and fourth degree perineal tears. Now, Australia, once again, is a leading light in third and fourth degree perineal tears. So when we first raised this as an area we should look at, and funnily enough, it sort of came out of the, to a certain extent, it came out of the C-section sort of issues. When we originally consulted on whether we should look at that, was there in fact anything that we could do about it? Because it was quite shocking to see what happened to a woman after a fourth degree tear. Most, as you know, never really recover from it. I met with very senior obstetric people and midwives who explained to me this story. Dr. Hercus, you'll need to concentrate. The story was this, that you have a vagina and it is a certain size. Then you have a baby's head, and the baby's head is bigger, and there is just going to be a tear. There is nothing that you can do about it. Now, that conversation actually took place in this office. Now, it took us 12 months to get to the point where people agreed that we could reduce the rate of third and fourth degree perineal tears, and that there was a way to approach that. So we often come to these conversations a little bit annoyed that someone's even raising it with us, with some pretty heavy duty, we've been around a long time, we've been providing excellent care for a long time, our patients are getting great results. But sometimes, as they say, bad things happen, but there's not anything you can do about it. And we do have to spend a fair amount of time working people through that. But for me, that was one of the main ones. I was basically told that's life. That's just going to happen. And now we're developing a clinical care standard to reduce third and fourth degree perineal tears, and it's a major focus of that clinical community to do something about it. So I see that as an incredibly positive change.
I think the important question always, I mean, people can argue about all sorts of things, but the most important question is, can we do better? And I'd be very impressed if somebody said, no, we can't do any better. We are as good is. But that's the really important question.
But having said that, when I was a chief executive officer and when I was director general, if I had $1 for every hospital that told me they were doing better than the hospital up the road,
but is it good enough?
I would be a very wealthy woman. But they honestly believed it.
But is that good enough? I mean, the key question is, if you think you're better than someone else, are you as good?
Well, it's not only that, but are you?
Oh, yes. Yeah.
And of course they weren't. Now, the reason for that is we are not providing enough information for clinicians. There's no question. You tend not to see those sort of home truths where you've got really good clinical registries running, for argument's sake. So from our point of view here at the Commission, one of the reasons we were very keen to run with the Atlas was to provide that information directly to clinicians. And I think that's been one of the big success stories of the Atlas. I don't think they had any idea about their antibiotic prescribing until we raised it with them.
I don't think we had any.
We had no idea. We were shocked.
Yes.
We were shocked about the attention deficit disorder medication, the use of antipsychotic medications in older people inappropriately to sedate them. So the Atlas is very important for providing that information.
And to, I think, focus the healthcare system on the consumer. That is the objective of the exercise, is the consumer. We often provide data from our hospital focus of how much we do. But I think variation, the Atlas series, and the work that we should be doing is consumer focused on how well people are receiving what we know is the best care, and avoiding care that we know is harmful.
Thank you. Mention antibiotics. Clearly, early atlases had huge variation in the rates of antipsychotic use across all age groups. One of the questions on the chat line is around whether you have information or can you share any lessons learned around how to successfully implement strategies to address inappropriate antipsychotic use.
This is the inappropriate use of antipsychotics
across all age groups.
All right.
Start with age care.
So let's just start with the really most inappropriate use. And it is changing, but it has taken an awful long time and a lot of work. And that, of course, is the inappropriate use of antipsychotics for the purposes of sedating people who have a cognitive impairment. The reason we want to sedate them is we don't want them running around, and they're a lot easier to manage. I think that's been one of the great success stories of the Atlas. We were one of the first groups to actually bring that to the community's attention. We then were able to bring it to all of the Australian Departments of Health's attention. It is actually a human rights issue, and it's taken time. It's been the subject of very significant evidence during the Royal Commission, and we're slowly seeing those inappropriate prescriptions dropping. And you know what? It wasn't hard to change it. Where the problem was that the script was written, and then the nurses, and often not even qualified nurses, were then giving the medication out as a PRN, and then the orders were never updated. So a person could be on an antipsychotic prescription PRN for 12 months. So there were regulatory changes made, and they've been very significant impact.
Thank you very much. So I'd like to thank Professor Duggan and Professor Piccone for today's session. Today is the first of 5 similar sessions. We have 2 next week on opioids in general practice and 1 on opioid prescribing in hospitals. And then we have 2 on the nuts and bolts of variation. 1 on practical tips for doing more around measuring and understanding variation. And then another one on using the standards as a roadmap to decrease variation. So I'd like to encourage everyone who's on today to look at the Better Care Everywhere website to look at the 4 upcoming sessions, which I'm sure will be as interactive and interesting as today. I'd like to thank the steering committee for organising the seminar. I think I'd like to thank a whole series of commission staff who have done enormous amounts of work to get this seminar series up. As many of you will know, we were going to have a face-to-face conference last year, but with COVID, we've had to morph to this seminar type online series. And you'll all be pleased to know that as of tomorrow, all the sessions of today will be up on the web. So you could use them in your hospitals for in-service, in your general practice for educating other colleagues and staff around variation and the importance of measuring and looking at variation. So as of tomorrow, this seminar will be up on the website. There are significantly more questions than we could answer. And I'm sure Professor Piccone and Professor Duggan will be happy that we've stopped quizzing them.
No, we're not.
One of the things that's been coming through is that everyone really appreciates the down-to-earth, real-world experience of both of you, Professor Piccone and Duggan, without framing a marshmallow view of the world, but being actually honest and calling out variation where there is variation. So thank you everyone for joining us today on this webinar. We've had about 800 participants. We've recorded all your questions. If your question wasn't answered and you'd wish to pursue the question, please send us an email and we'll attempt to answer it for you. As I said, the next 4 sessions will actually give you some of the nuts and bolts on how to examine and analyse variation and what you might do about it, both at a jurisdictional level or a private hospital level, and in your own practice. So thank you for everyone for joining us. And with that, I'd like to declare the webinar over. Thank you.
Well done.
Thank you.
Thank you.